Thank you all. And now Senator Feinstein.
Well, thank you very much, Mr. Chairman. First of all, I think this hearing has been very good, and I want to thank this panel because it brought out a number of questions. My concern always has been between Schedule 1 and Schedule 2 is the increase in the THC factor that's been done by calculation by growers of marijuana to produce a more stimulating, I'll use the word hallucinogenic loosely, drug. And there's a lot of it in California. And it concerns me greatly because young people use it. It is also a gateway drug. They go on to other things, and it's problematic. But here we have a situation which really seems eminently solvable. One would be some form of waiver, as you point out, Doctor. Another would be to add to the appropriations, which I am certainly prepared to do as an appropriator, and with the help of the people sitting on this dais, I think we could achieve that to speed the process along. I want to ask Dr. Minahan, if I might, some questions. What do you pay a month for the drug that you buy for your child?
At one point, it was $2,500 a month, and then have it tested at $168 a bottle. On top of that, it's not access for an average American. Not that now.
Yeah.
I have.
How do you know that the dose you're giving her is consistent?
You can have each bottle tested. Outside of that, we got a
bottle. Do you do that? Do you have each bottle?
Not each one, no. Sometimes you roll the dice and you go, well, they've been consistent this long, do you now test it again? I think we kind of believe it, kind of thing.
Yeah.
It's a roll the dice thing. But there's been bottles that showed up that said one thing and was completely the opposite, a very low THC, and it was a very high THC. And we got an email from them, hey, sorry. Sorry?
Oh, thanks a lot.
Yeah. In fact, they wanted it back because they're going to give it to cancer
patients. Is that right?
Yeah.
Because they'd resell it?
Yeah.
See, and that's the marketplace. I can speak about California where there's no real regulation. So you don't know what you get.
But if I was in Texas.
So the question comes, there's only one way to get it, and that's to get this process expanded and get it legitimized and get it regulated. And I think those are the things that we have to do and do as quickly as we can. And I hope this doesn't conflate with recreational marijuana, because this is totally different. And I think, Dr. Ingram, you pointed out a lot of the very real problems that exist out there on the streets that people may not want to believe, but it's happening in the emergency rooms, all over this country. And so could you comment, Doctor, on what you would do to waive the Schedule 1 for this drug? What specific would you waive?
Well, I think you would waive the registration requirements, or you can be a little more conservative and say, we're going to temporarily waive them. In other words, you're a doctor that wants to handle this. We're not going to make you wait 3 months to decide that, or a month, or whatever the average time was. We're going to automatically grant it to you, and then when DEA gets around to it, we're going to make sure you're handling it in the right way.
As long as you have an MD.
Yeah, I mean, it could be, I would say, you could have board certified for this. You'd maybe want board certified epileptologist, neurologist. I will defer to Dr. Ingram and Dr. Minahan on that. But yeah, I think you would. And then that would be, you could then have somebody who's a doctor-patient relationship, not email relationship with an unknown person from social media. Doctor-patient relationship, and then because remember, a lot of these INDs that GW is doing, there is a limit on the number of patients per doctor. So you could, right, Dr. Ingram? So
yes. You
could expand that. You could, do it with other products, and you really could do this absolutely within Schedule 1.
Can I finish?
Sorry. Excuse me.
Could the other doctors comment, please? Dr. Minahan, do you have thoughts on this? No? You don't have to.
No, I'll defer to the
Okay.
epileptologist.
You know, so my own process was with applying for a Schedule I license has been a little bit of a stutter stop. You know, I'll get an email saying we've gotten everything, we haven't. The real life process of getting a DEA license is for CBD is just like any other Schedule I, even though on the application you select what you're applying for a research Schedule I license, and you select what product is there. So I would make the case that there would be and I don't know, this may be part of the fast track process that Dr. Throckmorton was discussing. I think that if a person is applying for CBD research in epilepsy, and I don't have a problem with them submitting their research protocol. I think his point of the worst case scenario here is that we make this, we give this the illusion that doctors understand that it's okay. You know, we need more information to be able to say this is okay. We don't even really know what dose to give it. We don't know if you need to give it once a day, twice a day. Everything that we have is given to us by kind of growers, dispensaries, that sort of thing. And it's good data. Some of it's very good data. But I can't go to those growers and say, give me a little bit, let me do some research with it. I have to get mine from the DEA and NIDA. So I think the concept of, you know, one thing that could maybe be removed is like you have to add in the extra step of a site visit. And of course you need a site visit if you're doing cocaine research or you're even doing THC research. But getting a regular DEA license, a Schedule II, you mail it in, you send your money, they send you back your DEA license a couple of weeks later. That process really is not that onerous. This process where you add in all this extra stuff and you need all these site visits and all that sort of thing, it's a little bit more difficult.
And you can do those site visits later. I mean, even if people push back.
My time is up, but what I'd like to request is that you, the three of you, put in writing your thoughts on this specific question and send it to our committee, because I think both the chairman and I would like to take some action, and the question is how refined we make that action and that we know what we're doing when we're doing it. So your help would be, and anybody else out there, and I think we'll talk to Dr. Throckmorton more about this as well. So thank you very much, and best of good fortune to you, Dr. Minahan, and your little girl.
Thank you for having me.
Senator Gillibrand.
So I want to continue to probe on this issue that Senator Feinstein started, the difference between Schedule I and Schedule II. Do you have a license to do any research for Schedule II?
So Schedule II license, any neurologist in America is going to have to practice. We have to have it for stimulants. We have to have it for antipsychotics. So right now I have a Schedule II license. The Schedule I is not something that most of us have just offhand. And so that has to be applied for before we can do any research in this.
So do you believe if we changed it from Schedule I to Schedule II, the result would be more people would do research?
I think it would. You know, there's a big difference between product development and entry-level research. And I think that a lot of physicians hit this on first blush and go, ugh, or they try that first step and it doesn't go right, and so they just walk away from it. And that's why I say I think from a us standpoint, on our side of the street, I think a Schedule II, and that's been one of the calls of the American Epilepsy, all these societies, is that we degrade that, or at least analyze it as a barrier to research. It's a little bit of a decision I'm glad I don't have to be the one to make about where it fits, because I don't want it to become Schedule II in the product development side of things until we know for sure what we're dealing with. So I think that there's a mixed message there. I think leaving it Schedule I, but making it a much more expedited process, removing the site visit, preferentially moving those studies to the top of a pile, understanding that CBD and THC research are two separate things. And the other thing that I didn't mention before that is of supernatural importance here is that if I get my DEA license tomorrow and I live in Iowa, or I live in California, or I live in New York or New Jersey, I get my DEA license tomorrow, but I don't have access to CBD, it doesn't work.
Right.
It doesn't work.
So what the other thing we're trying to do is to change the number of places that can grow marijuana so that we have more access. Because having just one source of the medicine to research or the plant to research isn't enough.
Yes, ma'am.
And even as described earlier by our FDA witness, to have, or by you specifically, that you're limited in how much you can get seems crazy.
Yeah.
Since there are so few physicians who are willing to do this research. Again, it sounds like these are barriers to research.
You know, the funny thing about that, Mississippi has a lot of farmland. We can grow as much weed as you need, Dr. Gillibrand. The funny thing about that is that restriction is not a geography thing. It's not a physical plant problem, referring to the farm, not the actual physical plant. It's a problem with, right now Oxford has enough product to make 30 kilograms of product, 30 times what they have been allowed to grow through NIDA. And so everything that they grow is, and of course it all has to be secured funding up front. He's absolutely right. The money is where this ultimately leads. But all of that funding through NIH and then through NIDA is what limits us. It's not our physical plant per se. Now, we can get discussions of distribution and that sort of thing and how do we get it to and fro. Very little of the already commercially grade marijuana that's grown in Oxford is actually used in Mississippi. It's farmed out and sent to other places around the country, and in fact is sold in states like California and Colorado. But what we need, it's not an issue with how fast can we grow it.
Schedule 2, would you have been given the amount that you asked for? Like, I'm concerned
I don't know.
that the researchers who are willing to do this research aren't getting timely access and aren't getting the amount they need quickly enough, because
I don't know, but I can say that we all agree that 1 month of study on 50 patients is not enough.
it's not enough. It
not
seems
enough.
absurd. So I want to have clarification, and I would like you to add this to your letter to Senator Feinstein. What are these barriers specifically? Because we don't know enough to figure out how do we reduce the barriers. And the reason why many of us believe moving into Schedule 2 will reduce the barriers, because other serious drugs are within Schedule 2 and have very good ability to restrict, but it does open up access to research. Because the other thing is if we just waive for one strain, the last testimony you said that there was many strains. There was like, I don't know, how many did you say? There was
So there are 80 plus cannabinoids, plus 300 other compounds in marijuana.
Right, so if we're only going to waive it for one, to do the research on one, that seems absurd. Why aren't we doing the research on all of it? Why aren't we incentivizing scientists and doctors to do the research on all of it? Because I hear from patients not just who have seizures. I hear from patients who have PTSD. Our veterans are suffering from post-traumatic stress disorder, and they have seen very positive results with various use. We've seen people with MS. We have patients with glaucoma. We have patients with cancer. And so my question is, why are we not allowing research on every aspect of this plant so we can cure diseases, solve problems, just as we did with very, very harsh chemicals and products like heroin? We've done research. We've made cocaine Schedule 2 so more research can be done. We have many opioid derivatives now that are very good pain relief. I don't know why we don't treat it like opiates and do the proper research. I'm also concerned that we have only one drug company who wants to do this right now because it doesn't make money. If it's a Schedule 1 drug and it's illegal and dads are worried, I don't want to break the law, but I want to save my child, it's absurd that we are creating impediments to basic research. We do this with other serious drugs. I don't know why we're not doing it with this one.